Yes,
Yeah,
yes.
we should.
49 people are there. We can start. Sir.
Fine. Sure.
Good morning, everyone. Very warm welcome to all of you on this beautiful Sunday morning in yet another session of Scholarly Sunday. This is an 8th edition of our 4th series of PG Psychiatric Education Program. And the plan is, as always, to have an effective academic discussion with the guidance of our faculty. To begin today's session, I would like to invite Dr. Bhave sir, our president, for having his introductory speech, please. Thank you, sir.
Yeah, thank you, Saili. It's again a great pleasure joining on this scholarly Sunday morning. Saili, isn't it the 9th program? We started in December 24.
Mhm.
It should be 9th, I think. Right?
Yes, yes.
We're having it every month.
Yes.
Oh,
And-
yes, yes.
So it's a big pleasure. Dr. Sushil is now tired of me praising him every month in this quarterly Sunday program. So today I'm not going to praise him. I'm not going to say that he's doing wonderful work.
क्यों?
Not going to say that he
YouTube पे आ जाएगा
creativity.
record
आता है क्या? उस दिन आया था पक्का? देखो
Uh,
लाइव सेशन तुम आंसर करो ना.
Sakshi,
presentation
please
है.
mute yourself. Sakshi,
Podcast.
mute yourself.
मैं भी होता है.
As I was saying, I was
Sakshi
not going to say that he's very creative. I'm not going to say that he has
Sakshi, please.
wonderful work. And I mean, it's a great pleasure joining today. And as always, he has come up with a theme which is very practically very, very useful for the residents. I mean, for the last 7, 8 months, we have been seeing that every single session has been extremely well attended, breaking records of attendance in the West Zone. And I think that's understandable. I mean, looking at the utility of the nature of programs that he has been having, it's no wonder that, I mean, PG students throng to this program. And I'm sure today it would be no different from the earlier programs. So wishing all the best to all the participants and the audience so that, I mean, today by the end of 1 hour, they have learned much through also our erudite faculty, Dr. Kirpekar and Dr. Umate. So thank you so much, Saili. Over to you.
Thanks a lot, sir. Thank you for your guidance. Now, next, I would like Dr. Gawande sir, our chairperson, to have his address to our audience, please. Thank you, sir.
Okay. Good morning, everyone. Am I audible, Saili?
Yeah.
Yes, sir.
Yes. So I won't take much time. And thank you, Bhave sir. Thank you for the guidance and all the praise I am receiving over last 9 months. And at the outset, I thank Kirpekar sir and Maithili for joining us today in spite of Sunday. Thank you so much, sir, and thank you, Saili, for taking all efforts to organize this program. So, without a further ado, I hand over the platform to Saili for the proceedings of the scholarly Sunday session. Today, we will have 2 short cases, and we have organized all the sessions according to the needs of students. Students are going for their exams in the month of November. So we have these programs till October. So we thought of keeping 2 short cases this month, and next month, that would be in the month of September, we would have a long case presentation. So we started with how to write theory paper, then how to appear for the practical examinations, then how to write diagnostic formulations, then how to remember the images, then how to remember graphs and all that, which will be useful to you all in preparing for your exam. So best wishes to all the presenters and to our moderators. Thank you so much.
Thank you so much, sir, for your encouraging words that has set the stage for session ahead. Now, I would like to introduce our esteemed faculty. We are privileged to have with us Dr. Vivek Kirpekar, sir. He is professor and head of the Department of Psychiatry at LKP Sarve Institute of Medical Sciences and Research Center, Nagpur. Sir is a past president of IPS West Zone. He is an advisor for a psychotherapy subcommittee of Indian Psychiatric Society. Sir was a chairperson of election committee of Indian Psychiatric Society. Currently, he is serving as chairperson of election committee of IPS West Zone. We welcome you, sir.
Thank you.
Thank you, sir. Our next expert is Dr. Maithili Umate, ma'am. She is an associate professor in the Department of Psychiatry at the Grant GMC and JJ Hospital, Mumbai. She is a joint web editor of Bombay Psychiatric Society. She is a member of Doctors Wellness Subcommittee of IPS West Zone. She was an convener of research committee of IPS West Zone. She has been graced with awards like Best Lecturer in 2024 and Excellent Service in 2020. Okay, so we welcome you, ma'am. It is a pleasure to have both of you with us. I guess, yes, ma'am, with all your permission, I would like to proceed with the today's session. So before inviting Dr. Yash for his presentation, I'll just walk you through the program today. So we'll be having presentation of the cases, which are short cases. Dr. Yash and Dr. Akshay would be presenting case on ADHD. And after presentation, they'll be having a viva and demonstration for the same. The same sequence will be followed for the next cases, which would be presented by Dr. Yagani and Dr. Akash. So, with your permission, I would like to.
Saili, may I interfere little bit?
Yes, yes.
Maithili and Vivek sir, we told the participants to present it exactly the way they present short case in our exam. So it won't be too descriptive. It would be just like a short case they present in an exam. So in a typically in exam, they need to finish short case in 10 minutes and present their findings in 5 minutes, and then there is a discussion for the 10 minutes. So that's the reason there is not too many details which we usually have in a long case. So it's not by mistake they are doing it. It's purposely they are making it to look like the short case of the exam. That's it.
Can I talk a little bit before we start?
Yes, sir.
Yes.
So all the PG students should realize that the examination starts with long case, and examiners, at least two of them have traveled long distances and have reached for the examination. Many of them are tired, and we start our examination with long cases. So there are 4 or 5 long cases. Then we have short cases. So by the time you start having short cases, the examiners have started becoming inattentive and also somewhat tired, because most of them are 50 plus. So all students have to remember that whatever they present should attract attention. It should not become boring. So it is your job to make the examiner attentive, to arouse his attention. So it is important to present salient features, important features, and definitely that will give you more marks. So that is very important. Your answer should be very neat, up to date and precise. And if you don't know anything, you should not jumble with your words. You can jolly well say, I don't know, because very few of us know 100% of psychiatry. So that is pardonable. And it is advised that as far as possible, mistakes should be avoided. It may be 30, 40 marks, but those marks count when you fight for the top position. So remember those things.
I'm sure they are noting it down, sir. So we'll go ahead, sir.
Yes.
Dr. Yash, are you there?
Yes, ma'am.
Okay, I think you should start with the presentation, please.
Yes. So, hello, good morning, everyone. I'm respected faculty. Today, I'm presenting a short case.
Yes, please put your video on.
Yes, sir. Yes, sir. हाँ, sir. हाँ, sir. An 8-year-old boy, Master ABC, accompanied by his mother, presented with the complaints of the difficulty in remaining seated and constant fidgeting, along with the poor attention span and distractibility for the past 2 years. He is also noted to act impulsively, often interrupting others and having a difficulty to waiting for his turn. Symptoms are present in the both home and the school setting at a gradual onset and have persisted for more than 6 months, significantly impaired academic performance and the peer relationships. There is no history of any seizures, head injury, or the chronic medical illness, and no substance use or no feature suggested of the mood, psychotic, or the anxiety disorder. The birth and the developmental milestones were age appropriate noted. Ma'am, the next slide, please.
Yes.
Ma'am, the next slide, please. On the mental status examination, during the mental status examination, the child is frequently changing his posture and fidgeting during the interview. Speech is of a normal rate and the volume, but occasionally intrusive. Mood is reported as a fine with the appropriate and the reactive effect. Thought and the perception shows no abnormality, but the attention and the concentration are markedly impaired. With the child is easily distracted by the surrounding stimuli, and the intelligence was average, and the memory and the language are intact, and the judgment also are appropriate of the age. So, according to my assessment,
You are not audible sometimes. You come closer to the screen.
yes, sir. Sir, am I audible now, sir?
Now, yes.
Yes. So, according to my assessment, my observation, sir, my diagnosis of this patient is the attention ADHD with mixed this thing, hyperactivity and this thing, and inattentive. And yes, yes, sir. Hello, sir.
Hello.
Hello.
Yes.
Yes, ma'am.
Yes.
Ma'am, sir, I would like you to please start the Viva and further proceedings, please.
Yes. So you wish to ask?
तुम्ही सुरू करा.
Acha, Dr. Yash, you have mentioned that he also had impaired academic performance.
Yes, ma'am.
Yes. Clinically, have you assessed for his intelligence as well on the child?
Yes, ma'am. I've assessed while taking the case, ma'am.
Okay. Okay. So can you just demonstrate how you assessed for the intelligence? Bedside?
Intelligent.
Yes.
Yes, ma'am.
Can you demonstrate on the child?
Yes. Ma'am, this is a 8-year-old boy, Master Akshay. Yeah. Hello, Akshay. Akshay, hello.
Hello.
Good morning.
Good morning.
How are you?
I'm good.
Okay. Okay. Akshay, आज कहाँ पर आए हो तुम आज?
Hospital.
Okay, great. Can you name the hospital? Can you name it of this hospital?
Hospital.
Okay, ठीक है. अक्षय, कौन से स्टैंडर्ड में पढ़ते हो तुम?
2.
सेकंड स्टैंडर्ड.
Second.
ओके, ठीक है.
Okay.
बहुत से स्कूल. ठीक है. ठीक. तुम्हारे स्कूल का नाम क्या है अक्षय?
Xavier's.
ओके. और तुम्हारे क्लास टीचर का नाम?
Gavande sir.
ठीक है. एक बात बताओ, तुम्हारे कंट्री का नाम क्या है? What's the country's name? Okay. Your country's name?
India.
Great. And do you know what is the capital of the India?
Delhi.
Okay, Delhi. Nice. Good job. Okay. And tell me, in which city you are living? अक्षय, कौन से सिटी में रहते हो? तुम्हारे सिटी का नाम क्या है?
नागपुर.
Yes, नागपुर. And नागपुर कौन से स्टेट में आता है? अक्षय, good. Good. पहले बताओ तुम्हारे सिटी तो कौन से तुम्हारे स्टेट का नाम क्या है?
Maharashtra.
Yes, Maharashtra. Okay. Okay, Akshay, tell me one thing. First thing. Okay, great. पहले इधर आओ, बैठ जाओ. Just tell me one thing. तुम्हारे how many friends do you have?
I have 3 friends.
3 friends.
3.
Okay. And what is your favorite fruit?
Mango.
Mango. Okay, great. तो अगर suppose तुम्हारे पास 2 मैंगो है, इधर देखो अक्षय, अगर suppose तुम्हारे पास 2 मैंगो है और मम्मा ने तुमको 3 मैंगोज और दिए, तो तुम्हारे पास अभी कितने मैंगोज है?
1, 2, 3, 4, 5.
5 मैंगोज है.
5.
Right. Okay. Now tell me, अगर ये 5 मैंगोज है और तुम्हारे 3 फ्रेंड्स है और तुम्हें उसमें उसको देना है, तो तुम हर एक को कितना मैंगो दोगे? अगर तुम्हारे पास 5 मैंगोज है और तुम्हें तुम्हारे 3 फ्रेंड्स को देने हैं, तो तुम हर एक को कितना मैंगो दोगे?
1.
ओके, तो तुम्हारे पास कितने बचेंगे?
2 mangoes.
2 मैंगोज. ठीक है. एंड अगर तुम्हारे पास सपोज मम्मा ने तुमको 6 मैंगोज दिए और तुम्हें बोला कि तुम्हें दोनों फ्रेंड्स को बराबर से देना है, तो इक्वली देने, तो तुम तो दोनों फ्रेंड्स को 6 मैंगोज को पर हर एक फ्रेंड को कितने मैंगोज दोगे?
3 mangoes.
3 मैंगोज. एक फ्रेंड को 3 दोगे या दोनों फ्रेंड को 3 दोगे?
दोनों फ्रेंड को 3 देंगे.
Okay. Great.
Yeah. So Dr. Yash, what were you looking for? What were you asking him?
I'm really checking for his, like I'm informally checking the IQ of this patient, like checking his the basic general knowledge about the
General fund of information. Yes.
and sorry, and another guy I'm checking the by the calculation, the basic calculation, if the patient is able to calculate it or not.
Yes. So the child is quite distractible already, right?
Yes. Patient
Yes.
is
In the history, could you get some leads like about how his intelligence could be? Because specifically you got a history of impaired academic performance. In
ma'am,
you have elicited something which could throw some light on his intelligence, probable intelligence.
ma'am, मतलब like in this मतलब like scholastic performance, he's मतलब like ma'am, because according to his mother, his mother मतलब like gave us a history that the child is not sitting at one place in the school time while having the discussion, मतलब like student teacher conversation is going on. He'll not attentive to the class and just stand up and go around and playing with the others compass and this and that.
Easy distractibility was there, and he was not for his turn to answer. He was constantly.
So these were the things which are pointing more towards the inattention, or you have also found out some symptoms of hyperactivity which you have got even in the history. I'm
Yes.
saying in terms of because his intelligence for intelligence, what else you could ask in history? Something you would ask maybe in the birth history, maybe?
The ma'am, in this case, the birth history was within the like the milestone were like achieved. So
Exactly. So you would ask for the milestones also, right?
yes, ma'am.
In the
Yes.
So in this child, the milestones were as per age.
Yes, ma'am.
Yes. Good. The child was pretty much inattentive,
Yes, ma'am.
right? You can see also that the child was easily distractible. Correct. Are there any specific bedside you can test for attention also? Well, in this case, the child is really very inattentive.
Yes, ma'am.
But is there something that you could assess for attention?
Ma'am, by giving him the serial subtraction of one of the one, and otherwise I can give like ask him to like digit span type like Monday to Sunday, and then I ask him to reverse the Sunday to Monday as well, ma'am.
So can you try with this child?
Sure, ma'am.
Can I interrupt?
Yes.
I have a funny question. The child is 8 years old, so you have to be aware of.
Sorry, sir. So voice is breaking, sir. Sorry.
The child is 8 years old. It is an 8-year-old child. Am I muted?
No,
It is an
you are
8-year-old
audible.
child. So you have to see that whatever questions that you ask should be answered by a child of 8 years old. That is very important. I don't think an 8-year-old child will know the capital of Maharashtra or anything like that. You have to become a teacher of a first or second standard student and ask relevant questions. That is very important, because otherwise your assessment will go wrong. If you ask the child to add 2 and 2, that would be okay for a second standard student. A child may be able to subtract 5 from 9. That is okay. But division and multiplication will probably become difficult.
Yes, sir.
And secondly, your history talks about only 2 years. Why 2 years?
Sir, when the child started, like from the kindergarten, from there his teacher started giving him a complaint about the child, and like and then only their parents started noticing like his changing of the behavior and all. Mother has noticed, but in the initial part she ignored his like his symptoms are persistent but ignored by the in initial part. And now that by the teacher and by the parents and the other fellows also the complaints are here, and that's why I put it as another 2 years, sir. Because mother gave
a child who has ADHD will be fidgety right from the early childhood, infancy. He will cry a lot. He will probably achieve milestones early. He will move a lot, and probably family members would notice his hyperactivity much earlier than 6 years age.
Yes,
So
sir.
it becomes more evident when the child joins school, a school where he has to be seated. Probably not in a kindergarten, but in a school where he has to follow certain rules about his place and everything else. There, the ADHD will become more evident. Right.
Yes.
So there should be some pointers even in the early childhood history.
Yes. Okay. Okay, sir. Yeah, keep it, sir. Okay, sir, shall I continue with this attention?
Secondly, in history, you mentioned about substance use. 8-year-old child, don't mention substance use. You
Yes,
can
sir.
talk about substance use by a mother, alcohol and everything else, but don't mention 8-year-old child having substance use.
Okay, sir. Okay. Okay.
Go ahead.
Yes.
Go ahead.
Okay. अक्षय, अच्छा अभी एक बात बताओ कि एक वीक में कितने मतलब डेज होते हैं? In 1 week, how many days are there?
7 days.
7 days. Yes. Can you name the 7 days?
Monday, Tuesday, Wednesday, Thursday, Friday, Saturday. Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday.
ठीक है. तो मंडे टू संडे अभी जो बोले, ठीक है? फिर अक्षय इधर देखो. मंडे टू संडे जो अभी तुम बोले, ठीक है? अभी संडे से रिवर्स में बोलना है एक बार, ठीक है? संडे टू हम वापस मंडे की तरफ जाएंगे. ट्राई करो. धीरे-धीरे, slowly.
Sunday, Saturday, Friday. Okay.
वो बताता हूँ. फ्राइडे के बाद क्या आता है?
Wednesday, Monday.
Oh. ओके एक बात बताओ, मामा ने तुमको अगर 20 रुपीज दिए है, सुनो, अगर मामा ने तुमको 20 रुपीज दिए है, 20 में से तुमको 3 रुपए की चॉकलेट ली तुमने, तो तुमको कितने रुपए वापस मिले हैं?
70.
70. ओके, अगर हम 17 में से भी और 3 माइनस करें तो
11.
Okay, fair enough, Yash. So what would you say?
So ma'am, the patient is like has a short attention span, so like he's not able to concentrate. I mean, he knows the answer. He like if he give attention, then he knows the answer. But because of the short attention span, he's not able to like give the correct answer like in this way. Yes. Okay,
So
ma'am.
your question is ADHD?
Mixed.
Your
Mixed.
expression is mixed.
Sorry. Yes.
Okay, so how would you like to manage this case?
Ma'am, in this case, we can like first start. We can start the medication. If we can start the medication, then I'll go with the methylphenidate only, and starting with the 5 milligram, and then proceed further, ma'am. 5 to 10 milligram per day, ma'am, and maximum up to the 40 milligram.
Okay, any other assessments you would want to do for this child? Now you had a very short time to assess the child. So anything further you would want to do?
To assess this, like
Or
to
any principles you would want to consider?
sorry, ma'am.
See, what happened is that you had a very short while to assess the child, right? So you any more assessments you would want to do?
Ma'am, to like to check the severity and the other thing, we can go by just one standard scale called Connors parent teacher scale, ma'am. You can assess our like to his symptoms and all. Yes,
Okay. Anything you would want to do? Test you would want to do where you are starting the child on methylphenidate? So, or any baseline investigations you would want to do?
Sure. For that, like it's
complete blood count, vitamin D, vitamin B12, and yes.
Sorry, ma'am. I'm not.
Okay.
What is the height of this child?
No, sorry, sir. I didn't measure the height.
Kirpekar sir, I think this is the most difficult question he could answer.
But this is a very easy tip I am giving him.
Yes, I got it. But as the patient is a dummy patient, okay.
I am giving him a tip so that he can answer Dr. Maithili's answer.
Yes, excellent. So you may add how much is the weight of the patient.
Yeah. So it was a tip for the student.
Yes, take clues from the question.
Many a times internal examiners tend to help their students, and we can't help directly, so we have to find some indirect way of helping. So student has to be vigilant to pick up the clue.
Yes. We can check the like a basic complete blood. We can do the blood examination like the complete blood count and his vitally. We can check that, and anthropometric assessment also we can do, ma'am, before starting the methylphenidate.
Yes, you should note down the weight, the height, especially you will need the weight for deciding the dosage further, right? You can also consider baseline ECG also.
It's baseline ECG.
Why do you need to know the weight and height?
Like sir,
Has it got any relation with growth retardation?
yes, sir.
Good. There is
Don't
this,
get anxious. We are here to help you and you are here to learn.
Yes, sir. Yes,
sir,
sir.
methylphenidate has like weight loss and appetite suppression is also there. So because of that, we need to know the weight before.
Sorry, we are not.
What are the different preparations of methylphenidate that you know of?
Different preparations, sir. So one of the oral, the extended release phase, then the one is for the transdermal patch is also there, sir.
Mm-hmm.
Then yes, oral extended
And liquid oral tablet and liquid formulations and transdermal patch.
Any other molecule that you can use for ADHD?
Atomoxetine, sir.
Kaun sa?
Atomoxetine.
Atomoxetine. Anything else?
Sir, then the non-stimulant like the clonidine, we can use.
Yeah, clonidine can also be used. How long will you give those molecules?
Sir, the time duration of the
At the beginning of session, I told you, if you don't know, say I don't know. So
sorry,
you
sir.
have.
Sorry, sir, we don't know the of these questions, sir.
Any non-pharmacological management that you may advise?
Who's it? So non-pharmacological management, what we can do is OT assessment we can do firstly. Secondly, that is this token therapy where we give patient we ask the parents to give tokens to the child. We can do that also. And there is yes, sir.
Anything else?
Shall I give a clue?
Yes, sir.
Yes, you are welcome.
So, like,
Yesterday, I had taken your class in a sensory integration room. So I told you various equipments and the tools we use for the children. So you may use some of the information from that class.
Yes, sir.
Sir, like psychological intervention, we can do like the psychoeducation, then the academic organization skill training, and the intense behavioral modification we can do. Any other social skill training we can do. And also like the classroom behavioral management is also in the psychological interventions.
In one setting, ADHD students are more comfortable. So there are some people who say that you have to teach scheduling to the parents and the child.
Yes.
Yes.
So in a scheduled activity, the ADHD, the hyperactivity and distractibility gets reduced. So you can talk to parents, mainly family therapy, parental education. Those things are very important.
Yes, sir.
Okay.
Yes.
Yes, good. Good presentation.
Thank you, ma'am. Thank you, sir.
Good, good.
Thank you.
Okay. Thank you, Dr. Yash and Dr. Akash. Thank you, sir. Thank you, ma'am. We'll proceed to our next case. Dr. Yagani,
Yes, ma'am.
you are ready?
Yes, ma'am.
Okay.
So good morning. I'll start with the neurology case. Presenting a case of a 62-year-old female, Mrs. A.V., right-handed, Hindi-speaking teacher by profession, resident of Mumbai Central, brought by her son with complaints of sudden onset weakness on the right side of the body and difficulty in speaking since past 12 years. Patient is a 62-year-old hypertensive female with ischemic heart disease, previously independent in activities of daily life. Still, she was well until 12 hours ago. When she woke up and went to the bathroom, she suddenly felt dizzy, no head injury reported. Soon after, developed inability to move the right arm and leg. This weakness was progressive with difficulty in speaking and deviation of angle of mouth to the left with drooling of Sarai. She was able to understand the commands but had difficulty in speaking. Currently, she is unable to raise the right arm above her head, perform fine hand activities, or get up from squatting position, and often her slipper slips off while walking on the right side. No history suggestive of any seizure, any loss of consciousness, tongue bite, incontinence, headache, and dysphagia, diplopia, nasal regurgitation, fever, sensory loss, or any cognitive decline. She was brought to the emergency department for further evaluation. Next slide, please. As mentioned earlier, she has a previous past history of hypertension since 10 years and ischemic heart disease in 6 years on erratic compliance. There's positive family history in the form of father having a stroke at the age of 70 years. Personal history is unremarkable. Next slide, please. On general examination, rest of the findings are unremarkable except for her BP, which was raised around 170 by 100 millimeters of mercury. In the neurological examination in higher mental, in language specifically, the speech was non-fluent with repetition, which was impaired. Next slide. In cranial nerve 7 examination, the lower half of the face, that there was weakness, that is the buccinator weakness was there. There was deviation of the mouth to the left side, and which suggested an upper motor neuron involvement, pattern of involvement of the facial nerve. Rest of the cranial nerves was intact. Sensory system, all the vibration, pain, temperature, touch were intact on both the sides. Next slide, please. In motor examination, tone was increased on the right side, except for the face, upper half of the face, which was normal. Next slide, please. In power, the power was around 2/5 in the right side. Left side, the power was normal, 5/5. Only in the face, in the lower half of the face, the power was low, whereas in the upper face, that is the frontalis muscle and orbicularis ocular muscle, the power was 5/5. Next, reflexes on the right side were brisk, around 3+, and the plantar was extensor, that is upgoing, in the right side. Cerebral examination, only the left side could be done, which was intact. Right side coordination could not be tested. The gait was circumduction, especially on the right side. So our diagnosis was right hemiparesis with upper motor neuron type facial palsy and Broca's aphasia, probably secondary to an acute ischemic stroke involving the left middle cerebral artery in a 62-year-old hypertensive female with a history of ischemic heart disease. Thank you.
Good presentation.
Thank you, sir.
Yes.
I would like our faculty to start the viva and demonstration, please. Thank you.
So you have checked all the neurological assessment,
Yes, sir.
right? So can you demonstrate the seventh nerve?
Yes, sir.
Because that is one that is asked in examination quite often.
Yes.
So I would like to demonstrate the seventh nerve, a facial nerve. So facial nerve is a mixed nerve. It has motor supply, sensory supply, and secretomotor. But in exam, I would like to start with the motor examinations. So facial nerve basically supply the muscles of the facial muscles. So the first I'll begin with the frontalis muscle. So in the frontalis muscle, we have to instruct the patient to raise their eyebrows and we have to look for the horizontal creases. So क्या आप अपने ऐसे ऊपर देख सकते हैं? Okay. So as we look, the patient had those horizontal creases and they were present on both the sides, which means there is no any weakness.
Again, there is one suggestion.
Yes.
Be courteous with the patient. You request.
Okay.
Now I am going to demonstrate these to my examiners. So I would be very happy if you cooperate. और मैं जैसे बताऊंगा वैसे आप प्लीज करिए.
Okay. So I'll begin again then.
No. This is only for you and others because these things count.
Okay.
You can't just suddenly jump on the patient and say karo, and then somebody gets aggressive and does not follow your commands. These things happen in examination.
Okay.
So it is always requesting to cooperate.
Okay. Secondly, I will check for the procerus muscle where we have to tell the patient to focus over the glabella. आपको आपके इस तरफ बहुत जोर दे इस तरह से. ठीक है. So as we can see, patient would able to do on both the sides. So there was no weakness. So this was the upper half of the face. Now the third, there is the orbicularis oculi, where we have to instruct the patient to close the eyes as tight as possible, and we have to instruct that we will try to open it, but they do not allow to open it. They have to resist. तो आपको आपकी आंखें टाइटली बंद करनी है. मैं उन्हें खोलने की कोशिश करूंगा, बट आपको रोकना है. ठीक है. So we will do on both the sides. So as we can see, patients able to close their eyes very tightly. So orbicularis oculi is also intact. Now the fourth muscle is the buccinator, where we'll tell the patient to puff their cheek. So आपको आपका मुंह इस तरीके से फुलाना. Okay. Then to assess whether there is a weakness or not, we have to press over the cheek on both the sides. Okay. So there was an escape of air when I pressed on the right side because there was a right-sided weakness. So this is how we check for buccinator. Then fifth is then orbicularis oculi, where we have to tell the patient, oris, where we tell the patient to whistle or they can smile. So आप इस तरीके से हंस सकते हैं. Okay. So as there is no deviation on either of side. So basically, if there is a right-sided paralysis, there will be deviation to the opposite side. Or we can also ask the patient to whistle or blow. आप इस तरह सीटी बजा सकते हैं. So this is how also we can check for orbicularis oris. And the last is the neck muscle, which is the platysma, where we have to instruct the patient to clench their teeth very tightly so that neck muscles could be prominent. आपको आपके दांत वो जोर से भींचने इस तरीके से. So both the neck muscles are also prominent. So this is how we examine for the motor muscles. And in case of sensory, as facial nerve supply anterior 2/3 of the tongue, so we can check for sensory like taste sensation. We can give some sweet or sour anything, and you have to tell them to identify the taste. And so this is how we examine mostly for facial.
Now one question: which side will you test first?
Which side?
Yes.
Okay. So, sir, first we will test on the normal so that we can.
That is important.
That is important because then only we can assess the like abnormal side. So first we look for a normal side.
Okay. And how will you test for aphasia? Like if you differentiate this from, how do you differentiate this from dysarthria? And how do you test for aphasia?
Okay. Sir, aphasia. So basically, there are two types of an aphasias, fluent and non-fluent aphasias. So I'll begin with aphasia examinations. So first of all, we have to check the spontaneity of the speech. where we can ask the patient, for example, the name of the patient, or we can ask them to tell their complete address. Okay. By checking the spontaneity, we can able to make out whether the speech is fluent or non-fluent. Then we can begin with the, then we can go whether it's sensory or motor, Broca's aphasia. So first of all, I'll check for the spontaneity. So आपको आपका नाम बताना है.
मेरा नाम यज्ञानी.
Okay. आपका कंप्लीट एड्रेस बताएंगे जहाँ आप अभी रहते हैं.
जी विपिन नायर हॉस्पिटल, आनंदराव मार्ग, मुंबई सेंट्रल.
Okay, so we can check the spontaneity. The speech is fluent. Then we will look for the aphasia. We basically check under the 3 headings: comprehension, naming, and the repetition. So in comprehension, we can check the comprehension by giving some verbal commands. So verbal commands, we can give a simple verbal commands and as well as the complex verbal commands. So in simple commands, we can just ask the patient to raise their suppose right hand. So क्या आप अपना right hand उठा सकते हैं? फिर से रख दीजिए. So this is how we give the simple commands. So a patient able to comprehend that they have to lift their right hand. In the complex command, we can give 2 to 3 step task. For example, आपको अपना right हाथ आपके left कान को छूना है. So this was the complex task. So this is how we assess for comprehension. Second is the naming. In naming, we can just show the patient other objects and we can tell to name it. क्या बता सकते हैं ये क्या चीज है?
पेन.
क्या आप बता सकते हैं ये क्या चीज है?
मोबाइल.
So we can check for naming. Then in the repetition, we can give some simple phrases. So the commonly we use like कच्चा पापड़ पक्का पापड़, and we tell the patient to repeat it. आपको मैं कुछ अभी एक लाइन बोलूंगा, आपको मेरे पीछे वो दोहरानी है, ठीक है? कच्चा पापड़ पक्का पापड़.
कच्चा पापड़ पक्का. कच्चा पापड़ पक्का पापड़.
Okay. So this is how we check for the repetition. And for comprehension, there are the additional also things which where you can give the written or write. We can write on the paper and we can tell the patient to do it what we have written. For example, I have written here कि close their both eyes. या पढ़ेंगे क्या लिखा है?
अपनी दोनों आंखें बंद करिए.
वैसा करेंगे बस. So this is we can check the whether the patient able to follow the written command. So in this way we can check for an aphasia. How we can differentiate between the sensory and motor? So in sensory aphasias, usually the problem is in comprehension that we have assessed, and the fluency and the repetition part will be normal. And in the motor aphasias, that is Broca's, the problem will be more on influency. So there will be very slow speech, which will be where there will be mostly absence of conjunction, adverbs, adjectives. So there will be language problem mostly in the motor aphasias.
Now it was good that you tested the written part of it. You can you made them read and act. On other side, you can also tell them to write. So
yes,
different components of aphasia you tested. That was very good of you. So congratulations, because normally we tend to only test hearing and speaking, but aphasia also has the writing component as well, and that should also be noticed. So very good of you.
Thank you, sir.
Now Maithili madam will take over.
Yes, very good. In your case, there was Broca's aphasia, right?
Yes.
Yes. So what all was impaired you had found?
It was a non-fluent speech. So they were very paucity of words in them. Repetition was also improved.
Okay. Okay. Good. So in this case, the patient is presented within 12 hours.
Yes.
So how would you like to manage?
So ma'am, we could start with since.
Ma'am, in management, first of all, we have to look for the window period. But since the patient has crossed the window period, which is of 4.5 hours, So there is no point of now like thrombolizing the patient. But if the patient would have come in within the window period, we could opt for IV thrombolysis with plasminogen activators like alteplase and acteplase. But now since the window period has been crossed, we first have to rule out whether which type of stroke it is, whether it's an ischemic or non-ischemic stroke. And we can go for the primary choice will be then MRI, but if patient is not affording, we can go for CT. So we will first identify the type of the stroke, and then secondly we can start with like blood thinners, aspirin, and this for hypertension we'll manage the antihypertensive, or for dyslipidemia we can give statins. So, and then slowly and gradually, after the recovery is there, we can go for the non-pharmacological management, where we can do a rehabilitation with occupational therapy, physiotherapy, slowly.
What are the possible psychiatric comorbidities that you often see with stroke?
Some depression could be there, especially in our case, where there's Broca's aphasia, where the comprehension is intact and patient knows that he's unable to speak. So depression is a very frequently comorbidity, psychiatric comorbidity. Sometimes we have vascular dementia as well. When there is anxiety, that could also be there. More than depression, anxiety, comorbid.
Mostly mood disorders and dementia will be the...
Yes. In this case, like you would go for an MRI preferably, right? If not, then the CT. So what would you expect where the lesion is?
So, ma'am, depending on the presentation, we are suspecting, because Broca's aphasia is there in the right hemiparesis, so mostly the dominant side and left middle cerebral artery territory, cortical region, frontal lobe. We will MRI, it is the diffusion weighted imaging that we prefer for the MRI. There will be a hyperintensity which will be seen in the region that is affected, inferior part of the frontal lobe.
Okay. Okay, good. So you would want to ask anything more, sir?
Suppose that patient has depression. You are giving antiplatelet agents. So which antidepressant will you use?
Certainly, escitalopram is also actually safe and it is proven also. But
sir, with an SSRI, there is a risk for bleeding. So we can opt for some other
fantastic
SNRIs or like NASA's or TCAs. But TCA also we will be very careful, because the risk for if there is an ischemic heart disease, so there will be cardiac abnormality. We can go for an SNRIs or NASA. But like SNRIs are not also
complete. You get 100%. You get 100%.
Okay.
We should not forget that SSRIs also cause bleeding, and aspirin and the other agents that are used in cerebrovascular or cardiovascular disorders, they can also cause bleeding. So there can be bleeding. So we have to avoid anything that will aggravate. Otherwise, we stop aspirin and put that person only on SSRI, because both work in a similar way, more or less. Okay, wonderful.
Yes, good. Very good.
Thank you.
Okay. Thank you, Dr. Yagani and Dr. Akash. That was a wonderful presentation. I guess both of the teams did so well, and with the demonstration as well as the presentation. I would like to ask our seniors if they have comments about the presentation or the session, or should I proceed with the program.
Sairi, if there are any questions by students, they can put in a chat box. We can take maybe 3-4 questions.
Sure. So I request our participants, the audience, to put their questions in the chat box, or if it is feasible, it would be welcomed if they have unmuted themselves and started their videos and asked directly to us.
Yes, there is one thing I would like to add. That is
Sure,
for
ma'am.
all students, I feel that you all shouldn't be nervous when you all are giving the examination. The examiners are there to understand how much you have grasped and how you are able to deal with patients in real case scenarios. And as Sir said, that when you have been asked to demonstrate, you understand that there's this person standing in front of you. So you take his permission, you request, and whenever you've been asked to demonstrate, do talk with the patient, do communicate.
And don't forget, we are not there to fail you deliberately. We are there to see that you pass. Most of the examiners tend to help, so you pick up clues. That is very important. And as less anxious, it is better. Many a times when we are anxious, we tend to forget answers that we know. Like we also have appeared for exam. I appeared almost 37 years ago. So it is always better to be less anxious.
Anxiety is a common component over those 37 years.
Yeah.
That is something which has not changed over a time. For students, Sairi, I have typed the non-pharmacological management of ADHD in the chat box. So I have
Yes.
put everything there. So they can just copy and paste and use those points for their exam. So, sir, with your permission and Maithili's permission, if there are no questions, can we sign out at this time?
Thank you so much for inviting
No,
us.
just wait for a vote of thanks by Sairi.
I would
we
be
can sign out.
As we come to the end of the session, I would like to express my heartfelt gratitude to our both the experts, our faculty, Dr. Kirpekar sir and Dr. Umate ma'am. Thank you very much for taking out your time on a Sunday morning and enlightening us with your knowledge and insights, sir and ma'am. Thanks a lot. I would like to thank Dr. Sudhir Bhave sir and Dr. Gawande sir for their constant support and guidance for such scholarly Sunday sessions, which are um, successful every time. I would like to thank PG Psychiatric Education Committee and Psychiatric Society of West Zone for organizing this enriching sessions and improving the academic knowledge of the students, PG students. Thank you to all the examinee who have actively participated and conducted this, made this session very successful. Thanks for your participation and your dedication. Finally, I thank all of you all for your active participation and to attend this session for joining us today. We look forward to see you all in our next Scholarly Sunday session. Have a great day ahead. Thank you very much. Thank you. Should
Thank
we
you, sir.
conclude?
Thank you.
Thank you.
Yes. Maithili, thank you so much.
Thank you. I would like to thank the entire Westwood, Bhavi sir, Dr. Sushil for inviting me here, Dr. Saili to be so cooperative, because sir, it was great to be an examiner with you.
येस म्हणजे गणपतीचं डेकोरेशन सोडून तू एक तास इकडे दिला. सो थँकफुल.
चलो,
थँक्यू
बाय बाय.